Hey everyone, and welcome. Today, we are diving into a topic you are absolutely going to see over and over again on the wards: acute bacterial GI infections. My goal here is to give you a really solid clinical framework so you can walk into that patient's room and tackle these cases with total confidence. All right, let's set the scene. You've got a patient with acute diarrhea. The first question that pops into everyone's head is, what's the bug? The list of potential culprits is huge, right? But hold on. Before you go spiraling down a rabbit hole of obscure pathogens, there is a much smarter first step.
And here it is. This is the single most powerful question you can ask right at the start. Is the diarrhea watery or is it bloody? Think of this as the first major fork in the road. Answering this one question immediately slices your differential diagnosis in half and points you toward two completely different types of infection.
So let's take that first path. Let's talk about profuse watery diarrhea. We call these pathogens the secretors for a very good reason. They don't actually invade your gut wall. Instead, they release toxins that basically trick your intestines into opening the floodgates and pouring out massive amounts of water and electrolytes. Now, in this category, there are two major players you need to know: Vibrio cholerae and E-tech. What's so interesting here is that they both lead to the same outcome: huge fluid loss. But their stories, their clinical settings, and their severity are really quite different. So Vibrio is the classic, most dramatic example of this. When you hear about a patient who ate raw shellfish, like oysters, or traveled to an area with contaminated water, your alarm bells should be ringing. The cholera toxin leads to this incredibly rapid, severe diarrhea. We call them rice water stools, and patients can become dangerously dehydrated in just hours. This is a true emergency where aggressive fluid resuscitation is everything.
And then we've got E-tech. Now, this is by far the most common cause of what we all know as traveler's diarrhea, or Montezuma's revenge. It uses a couple of toxins to cause a watery diarrhea that, while it's usually not as life-threatening as cholera, is still more than capable of ruining a vacation.
Okay, so that's the watery side of things. Let's back up to that fork in the road and go down the other path now: the bloody, inflammatory diarrhea. And this is a whole different ballgame. We call this group the invaders. They aren't just sending in toxins. They are physically breaking down the door, invading the intestinal wall, and causing a ton of inflammation, damage, and bleeding.
Yeah, so let's be super clear about what the term dysentery actually means. It's not just diarrhea with a little bit of blood. It is a full-blown inflammatory syndrome. When you see blood, mucus, fever, and serious abdominal pain, that's your sign that the gut lining, the mucosa, has been breached. The wall has been attacked. This table here is incredibly high yield. It breaks down the three main causes of dysentery you'll see: Shigella, Campylobacter, and EHC. I really want you to pay close attention to the common source and major complication columns. These are your best clues. For instance, you hear about an outbreak at a daycare, you have to think Shigella. You hear the patient ate undercooked chicken? Campylobacter should be at the top of your list, and you better be thinking about the risk of Guillain-Barré syndrome down the line. These details are crucial. Now let's zoom in on a huge diagnostic clue for one of these invaders: EEHC. It's a little counterintuitive. See, with most invasive infections, you'd expect a raging fever, right? But EEHC often breaks that rule. So if you have a patient with terrible bloody diarrhea and severe cramps, but they're afebrile or have just a low-grade temperature, you have to be highly suspicious of EEHC.
And this is why getting that diagnosis right is so critical. This is probably the most important clinical pearl in this entire explainer. Your gut instinct might be to start antibiotics, but in a patient with EHEC, that is a dangerous move. It can actually cause the bacteria to lyse and release a massive flood of something called Shiga-like toxin, which leads to a devastating complication.
And this is that complication: hemolytic uremic syndrome, or HUS. That Shiga toxin goes on to shred red blood cells, chew up platelets, and cause the kidneys to fail. It's a medical nightmare. So our number one goal when we suspect EHEC is supportive care and avoiding anything that might trigger HUS.
All right, so we've got our secretors and our invaders, but now let's talk about an organism that kind of breaks the rules: non-typhoidal salmonella. I like to call it the great impersonator because it doesn't always fit neatly into one box. It can cause watery diarrhea, or it can cause an inflammatory, bloody dysentery. It really keeps you on your toes.
So when should you think salmonella? The classic story involves poultry, eggs, or dairy. Now, for most healthy people, it's a self-limited illness that just needs supportive care. But, and this is a huge but, for our high-risk patients, like the very young, the elderly, or the immunocompromised, we absolutely treat with antibiotics. That's because in those patients, it has a nasty habit of escaping the gut and causing a dangerous bloodstream infection.
Okay, we've covered a lot of ground here. So how do we put all this together and make it useful at the bedside? When that patient comes in, what's your actual game plan?
It really comes down to this four-step approach. First, classify the syndrome. Is it watery or inflammatory? That's your first big decision point. Second, look for those red flag clues we talked about, like the afebrile bloody diarrhea. Third, assess your host. Is this a healthy 25-year-old or an 85-year-old on chemotherapy? And finally, once you have all that information, you can choose your therapy wisely, knowing when to give antibiotics and, just as importantly, when to hold off.
So, what's the big take-home message here? Understanding all the different bugs is important for sure, but more often than not, cracking the case comes down to just taking a really good history. The key to the diagnosis isn't always in a lab test, it's in the story. So ask, where have you been and what have you eaten? Those simple questions can be everything. That's it for this explainer. Thanks for joining me.